Lights, camera, action. Yeah, we're streaming. Morning, everyone. Welcome back. This session is called Population Health in Action. That's where you get to find out what public health physicians do. And I have to confess that it took me 6 years in medical school and another few years as house surgeons and registrars and another 4 or 5 years as specialty training before I even knew what public health medicine was, to be honest. And so we're hoping to remedy that now by getting this to you early to find out what people do who choose this specialty path in medicine. Myself, I trained in general medicine and then drifted into public health. And you will have heard from yesterday how people do kind of come in and out or towards public health. And that's, I guess, a bit par for the course, but there is actually a career pathway. And we're going to hear a little bit about that pathway as well as what people do in their daily life. So we've got, we're streaming at the moment. We're streaming into Pukawakawa and into the regional, the rural placement people. So Pukawakawa, I apologise that we're not doing this in person because we've got your person right here down with us. You're going to have to take this on the screen. All right, we're going to hear from 3 public health physicians. Or physicians in training, and we're going to get them to tell you a little bit about their work, and then we're going to have some Q&A at the end. So Michael Hale has gone down the public health track. He's been a public health physician as a senior public health and medical officer of health at Auckland Regional Public Health Service. Is that what you call yourself now? You probably, anyway. You can introduce what your specific title is throughout all of these changes. So Michael will tell you a little bit about his background and his story. So I'll let him introduce himself more formally. Michael, thank you.
Atamaria kia koutou. Great to be here. Thanks, Boyd, for the introduction. And I didn't know really anything about public health for a long time as well. So that's part of why I enjoy the opportunity of being able to talk at this kind of forum. What I knew when I was sitting there was a little bit of clinical epidemiology, and I was like, yep, that's great. I love those stats that you have. I love the epi, but just let me see real people and we'll talk later. But this might age me a little, but at the time I was also reading and getting concerned with a lot of global health issues, development issues, and recognizing that sort of the biggest thing for a poor country was the macroeconomic conditions within which they lived, and that even the amount of money they were spending on debt payment was far more than they'd be spending on their health system. So I guess my mind was triggered to like the big picture of things. I didn't realize that there was a medical department that was associated with that. I thought I'd have to retrain as a development economist. And so I was really delighted when I started doing some postgrad study and found a whole bunch of people who were public health registrars and jumped on there. So that was sort of my way into public health. And so, yeah, hopefully you guys have a few more ideas of what public health is before you start. So I'm going to talk about the medical officer of health role in New Zealand. It's one of the branches that sort of takes a number of us public health physicians, and this is a person named in the Health Act. We're a doctor responsible for a community rather than responsible for the person coming in. It might be responsible for the community of Gisborne, it might be responsible for the northern region, but that's where our sort of duty of care lies. And we work across communicable disease, environmental health, and more so now in the areas of health promotion and non-communicable disease and health equity. And there is some special powers within the Health Act, some things that get unlocked during pandemics, requisitioning vehicles, compelling people to be tested, these types of things They're very small print in the end of the day. The main part is what I've already covered. And so today I just thought it's best to just tell you a little bit about some of the stuff that I get up to just give you a kind of flavour for what the role might have, and explain a little bit about that. So a few little stories along the way from a bit of work in communicable disease control and non-communicable disease. So one of the aspects I love about the role is that it's focused on the big picture, and I think that's obviously going to be a driver for public health type people. So if you're in primary care and you're seeing someone with cough, coryza, paroxysms of cough, maybe some apneas, you're thinking whooping cough, and just like that, I'm thinking that as well, but I'm also looking at the big picture and checking trends like this epicurve from the start of the year, looking for patterns in ethnicity, patterns where people live, and also not just considering the other differential diagnoses, but we'll be bringing the big picture of what's the historical pattern here, knowing that pertussis usually lasts about 18 months, and that we're about 6 months into an outbreak now gives us some sort of indication of what might be coming, knowing that it also, in the last 2 outbreaks that you can see there, had a winter lull, as opposed to most diseases which have a winter takeoff, and then a spring-summer peak. That also gives us some big picture observations that we can share with clinicians, with those in the field as well. Another aspect about the role is in leadership, and one of the things that I've enjoyed is the ability to work with other specialists and sort of groups across the country, whether that be in a treatment advisory group, bringing the perspective of outbreak control, which is our basis, alongside, say, infectious disease and microbiology and pediatricians. Also in collaborating on things like an emergency management team gathering around a high-profile outbreak at a national level. Health advocacy is really key to the role, and so what often that means is explaining to people about why an issue is important. And so I might say I'm working with a council group or someone I'm trying to persuade about why we need to actually shift the systems and environments in which people live. And we could use an example like tobacco control. And so here, if you look, the red line is all tobacco sold, and down on the x-axis is over time, and you can see it going up and then precipitously decline. But I'll draw your attention to 1948. That's when the very first health department posters went up in New Zealand saying that smoking was bad for you. We beat the US Surgeon General by about 15 years. Pack warnings were then the next thing we did in 1974. And then you can see, sorry, the lines are a little hard to see in that colour, but the timelines of all of these environmental interventions kick in. And so what you can draw out from that, so we had over 25 years of education. So when someone tells you what we need to do about alcohol or some public health problem is we just need a bit more education. And then we had environmental change. And you tell me, where does the needle bend? Does education change outcomes? Or do we need to actually change the system, change the environment, and take it seriously? So health advocacy is something that I enjoy getting into. And then strategy as well. Actually being a part of that sort of big picture again. How are we going to address this issue? And so for pertussis, our strategy is around protecting the vulnerable, which really differs from something like measles or early phase COVID, where the strategy was elimination. Now, you can't do elimination with pertussis. It's endemic. We have a vaccine that gives waning immunity, so you would end up burning out your workforce and having to vaccinate everybody every 5 years. So what we do is we have a strategy that recognises both the context of the disease and the context of what treatments we have, and we build it up around those type of things. And so being involved in that is quite satisfying as well. Working on equity, health equity, is another key part of the role and something that is really satisfying. And looking on the left here, this was the whooping cough cases that we've seen in the last 12 months. And if you just were to take crude numbers, as is on the left, you might think, oh, predominantly affecting Pacifica and European populations. But actually we need to divide that by the denominator, as you guys would know. And what we can see is that instantly for the European population, actually having crude rates of half that's seen in Māori, a quarter that's seen in Pacific, and a half that's seen in Middle East and Asian America. And so that can help us direct both our resources and interventions to be addressing the priority populations. So using data to make health equity-based decisions. We're a specialty and my role is really data-led. So a couple of examples on that. This was one of our dashboards that we built and developed during the elimination phase of COVID. And this was looking at all of the quarantine facilities in Auckland and when they'd had a case, and then looking at the number of exposures and by overlaying spatio-temporal links to look for missing chains of transmission that we hadn't seen or been able to prove yet. And it also comes into non-communicable disease. So this is a dashboard that we have looking at affordability of food. And so the bottom left there is the food price index, a little bit similar to the consumer price index. And you can see there that from about 2022, we've had a dramatic increase with over 10% per annum rises in the cost of food for people. So again, looking at those environmental things when we're talking about food security, when we're talking about healthy diet, what does the actual economic drivers of that look like, especially when comparing to much lower changes in household income. And then taking some of this stuff and looking for action. So we worked with all of the local boards in Auckland, producing a safe speed scorecard report showing where the speed limit reductions were going to be around the schools in the area and what schools were missing out and whether they wanted to advocate for more. And this is myself and a surgeon and another epidemiologist talking to the elected members of Auckland Council in their Transport Committee, bringing a presentation on why transport is a public health issue. And one of the things that we were able to communicate was that, from air pollution alone, we get over 3,500 or almost 3,500 deaths a year from transport. And if we compare that to something like our highest mortality condition, cancer, which does about 9,500, we can see that sometimes even amongst the health profession, there is a lot of these non-communicable diseases and the attributable causes that are not being taken as seriously as they need. So working with council to get those kind of system and environmental changes implemented. And also addressing the commercial determinants of health is something in the role. So here we have 3 examples that were taken to the Advertising Standards Authority by our team, saying these are actually advertising to children. Now we have a regulatory regime that is run by the industry, so it's perhaps no surprise that despite featuring children as the main protagonists, cartoon characters, even having the word made for kids in there, that regulatory body run by the industry decided that all 3 of these things are not marketing to children, apparently. So yeah, communications is a big part of the role, whether that's giving warnings, alerts. It also comes to more complicated communication type stuff like social marketing, and that's a big aspect of the role. The last example I wanted to give was just something on that prevention focus that is a real element of public health that we bring. This one's pretty relevant and can't take the credit for this. This was colleagues in Southern. But a case of typhoid fever was notified a couple of months ago in someone who had 0 history of travel. Now that's not a condition that we expect to see in New Zealand. It's one that's always been imported in or someone has acquired it overseas. So they did a source investigation, interviewed them about any risky behaviours or places they'd been. They found that most foods were pretty low risk, but he'd frequented 2 food premises quite a lot. So they went in, did some source finding specimens on all the staff in those the food handlers in those premises. And interestingly, one of those returned a positive result for salmonella. And then this went on for whole genome sequencing and found that there were 0 SNP differences, as in it was a complete genetic match. So using this sort of investigation to be able to prove a link and then bring in council and MPI to work with them on some measures to improve food hygiene. Right, couldn't just tell you the good things. There's aspects of the role that are annoying, hard, as all jobs do. So, firstly, tackling vested interests and that commercial determinants and working with politicians and influencers. Change is going to be hard won. If we're addressing things like air quality, then we're taking on vehicle manufacturers that are making a heck of a lot of money selling big cars right now, and they don't want to change until that revenue stream is completely dried up. So there's a powerful opposition, lots to lose, and therefore we get non-linear progress. And sometimes, as we've seen in speed limits around schools, we get regression. We also often are working against groups that are quite happy to bend the truth, fabricate, work on pseudo-evidence, and we have a higher standard, so that we have to bring the right evidence to rebut that. And more recently, there's been moves to undermine the role of the expert, the role of science, the voice of public health in speaking to these things. And so that's definitely a challenge as well. The last thing is, there's not so much patient contact in what we do. And I miss the diagnostic dilemma, that thrill of figuring out what someone's got and what we need to do about it. And the other thing being that ongoing relationship with people. What is awesome is that we do get to work in teams, and so you still get that personal connection. It's just you won't get someone saying, "Thank you, doctor, for the great work that you did." So that's a little whistle stop through what it's like being a New Zealand Medical Officer of Health. Thanks, everybody.
We'll take questions at the beginning. Oh, yeah. Thanks so much, Press to show. We should be coming back onto this one by now. Oh no, lectern computer, there we go. Right, now I'm going to load up Carrie. Thanks, Michael, that was it's tremendous, and yes, a few frustrations I can imagine with some of those traffic, with the increases in speed and things, that puts your advocacy in a bit of a dilemma. Right, I'm just going to load up Carrie's, here we are, and this one, which one is it? This one here? Oh, top one. All right. All right, well, Carrie is down from Whangarei at the moment because she's just had something scanned. You might be able to guess what it is. So thank you, Carrie, for joining with us. So Carrie recently graduated as a public health physician and is up in Northland with support from Auckland, but there's a fair bit of distance between Northland and Auckland, so I'm sure we're going to hear about those challenges. And you heard yesterday from Mafi and Julie, who are the co-leads of the MAS Foundation, and Carrie joins me on the board of the MAS Foundation, and the MAS Foundation is what we're sort of basing this whole project on, that these guys are into. So, Carrie, welcome. Thank you.
Do I change it like that? Yeah. Kia ora koutou, ngā mihi nui kia koutou. So my name is Carrie Briers, and as Boyd has mentioned, I normally work as a medical officer of health and public health specialist in Northland, but I also work in Auckland, so I jump between two. And yes, I got a baby scan coming up today down here. So, which is one of the issues of healthcare access in Northland, which I will talk about probably quite a bit in my my spiel. So I thought, because I've been a consultant for a year, I thought I would focus more on my journey of how I've got to there and what I've learned in the last year. So I have a picture here of a picture in Auckland. So I was born and raised in a small rural town up north. Population was about 5,000, and I was initially raised by my dad. However, when about age 10, he became unwell, and so he had to go away for treatment. And in that time, for the next about 7 years or so, I was shifted around to different community members, including my teachers and employers, etc. So I lived with a range of different people in my community, and everyone was on board about this and what was going on. And similarly, my brothers were separated out to different people as well. There was myself and 2 brothers. The privilege of doing that, although it sounds a bit stressful, it was actually really humbling, and I got to see how different people lived and what that meant. And so what I ended up noticing was that they had the same health issues that I was seeing with my dad. And so I started asking questions around what is it that we do? How can we make our community well again? And so I started to become quite a strong advocate in my community through different avenues, particularly focusing on healthcare access. And so when I was 17, I was picked up by a program that had just started called Whakapiki. I was picked up on my last day of school and brought down here to Auckland because I hadn't been to Auckland before, and I started the foundation program. I then proceeded into pre-med year, and then I went into train as a nurse, and I worked at Middlemore ED. But I found at that time I was also wanting to work out a scope, so I wanted to do IV fluids and IV antibiotics, etc., which was not in the scope of a nurse at the time, and I was encouraged to go into medicine, so I did. Oops. So I was one of those students, then junior doctors, that loved every single run. I didn't know what I was going to do, but I knew from my bringing up that I was constantly questioning whether or not I was actually making an impact for what my community needed. The intention was that I would always go home. And so I was aware that we had massive issues around healthcare access in Northland. And so when I was working as a doctor up there, I knew I was only seeing the people that were coming in through the door. It was the ones that weren't coming in through the door that were really bugging me. And so on top of being a doctor, I would spend my weekends working in St John Ambulance and also after work. So I would go pick up people from their home, bring them in, and then the following morning I would present them as a junior doctor and give them a whole holistic overview with my nursing background, ambulance and medicine. So people said it was way too much, but anyway. But going into the homes gave me, again, that snapshot of what was going on for whānau. So I had a really good overview, and I knew that bringing them in, treating them was going to do absolutely nothing. You sent them back straight out to the same environment, they were going to pick up the same diseases, and it just felt like I was this definition of insanity to me. So there was also 2 graphs in my medical training that really stuck with me. The first one was this one. You would have seen it before, I'm sure, but it's the life expectancy graph at birth. And so particularly was drawn to the bottom line, the Māori males, and then there's a sort of pinkish line, which is the non-Māori males, and and as you can see, there's quite a large gap. It has got smaller, but there's a large inequity there, that unfair and unjust inequity that exists for our people. I placed my dad's Māori male, and so I was thinking about where he sits on this line and how much time I had left with him. And it's how unfair is this, that we have this, and why does this exist? The second graph that also sticks with me a lot is this one here. This is the deprivation map that we have. And so this is a map that we use a range of different factors or variables. So we look at employment, quality of housing and income, etc. And they get scaled. So 1 being the least deprived and 10 being the most deprived. And essentially what you can see here is pretty much north of Auckland. We live in a very most deprived area of New Zealand, so especially around that 7, 8, or 8, 9, 10 area. And so it was, so that plus, when I was practicing medicine, I always asked the but why question. So when someone, like if I was working in peds, the kid would come with a bronchiectasis and I would go, but why? Why have you done that? And so you know it's recurring infections, but why? And then bringing in the ambulance and seeing the home, I knew it had something to do with, for example, housing conditions. But why is that? So I kept going until I couldn't answer the question anymore. And it would give me that really big picture. And so that was when I realised that what I was seeing in the hospital was only about 20% of what was actually happening out in our community. And so that's when I realised that I needed to place myself outside the hospital doors and actually make change out in the community and try and prevent this from happening and coming in. So with that in mind, I entered into public health. It was a specialty that I also hadn't heard much of, but I think, apart from Boyd and Michael, I picked it up quite early. So PGY 1, I thought, yeah, this is where I'm heading, or PGY 2. And so I thought I would take a little bit of time to give you my perspective of it, so that when you go into practice clinical medicine, you can sort of think about what we're thinking of when we go through that way. So I'm going to use a cliff analogy, and my apologies if you've seen this already yesterday. I'm not sure, but I'll give you my version of the cliff analogy, which I've learned from Dr. Kamara Jones during my training. So, and these are my drawings, apologies. When it comes to health and wellbeing, we know that keeping well is best, but how do we do that? And so I want you to imagine that we have our communities who sit on this mountain, a mountain of good health. And so all mountains, unfortunately, have cliffs. And so you can imagine that someone's walking along and then, whoops, they fall off the cliff, right? So we met at the bottom of this with an ambulance, and they would take us to the ED, and that's what you see when they come into the ED. So that's all good and well. I wouldn't want to decline any ambulance, but the better idea would be that we'd try and not fall off the cliff in the first place. So what can we put in place to protect our communities and keep them safe? So some people would say perhaps some more ambulances, and that's not a bad idea, but then we don't want to put too much demand on these services, and so we ought to think about other things that would reduce that demand. So some people think about, what about putting up a fence that can catch people on their way down? Some people say, why don't we, oh sorry, that was a net, and then this one here is the fence. Why don't we put up a fence to stop people from falling in the first place? But sometimes the fence might not even work. And so particularly if there's a lot of people leaning against that fence, not even a really, really strong fence can stop people from falling off that cliff. So the idea of the mountain of good health is that we would eventually shift the people away from the edge of that cliff. And so we do this by addressing the range of factors that can affect our health, which are usually beyond our personal control. And so those are factors that I talk about where we talk about neighbourhood conditions, so whether or not you can have access to fresh food, healthy foods, whether or not you can access parks, whether or not you can you safely go for a run at night, for example. Or do you live in an environment where it's saturated in alcohol stores and tobacco and vaping stores, or criminal activity that changes the way that you interact in your own environment? It also includes things like income and poverty, whether or not you can access good education and therefore get a good job and therefore have a good income, etc. You can see the going on effects. And also, as I mentioned, whether or not you can access healthcare services. So these conditions is what we call the social determinants of health, and they, as I've mentioned, shape the way that we work and play in our environments. And so these determine how close people are to the fence or how far away they are. And so the ambulances, the net and the fence, these all have names. So we've got the ambulance here, which is the tertiary prevention. So that's when something's already happened and you've got to go into the hospital because you need to get better. The nets themselves are what we call the secondary prevention. So those are the preventative measures that we put in place to limit health issues within our community. And then you've got primary prevention here, which is preventing that illness from happening in the first place. Moving the population away from the cliff is what we call primordial prevention. And so that's where we look at those external conditions that can affect the health of our community. But it's important that we have all four of these components because they all need each other to operate well in a health system. So finally, the other point that I wanted to make is that on the mountain of good health, this is probably the most important point to take away, is that it's important to think about who is actually standing there and where are they standing, how close are they to that fence, and how good are those nets and fences and ambulances. So we know that on the mountain of good health that not everyone's got access to an ambulance, and that's particularly true up north. We know that for some places the fence might not be that good, it might have holes, it might not have been maintained. We know for a fence it might be broken, put actually somewhere else. It might be operating only between 8 and 5 p.m. So what do we do with people who work after hours? Well, we might be completely removed with no consultation with the community whatsoever. So, so the point is that we need to think about different communities and where they all stand, and how it affects these different communities. And so, I'll just go to my final slide, which is this is a picture of Northland when we come over the Brendouin Hills. So since doing public health, I would say my life has changed completely. I completely look at medicine differently. It's like putting on a pair of glasses and I now can't take them off. It's changed the way I operate and I think. Northland itself is an absolute paradise, but we are really affected by public health issues. We have hardly any ambulances. We've got nets that aren't maintained and quite a lot of broken fences. And so we've got areas of high deprivation, of rurality challenges. We don't have a lot of high-paying jobs. We have really poor access to services. So for some whānau, it means a 2 to 3 hour, sometimes 4 hour drive just one way to a pharmacy. And we're also constantly cut off by weather events, slips and flooding, etc. The strengths in this, and this is what I've learnt in the last year of the job, is that we do have a really resilient community who are so keen to get things going and to fix things and build these fences that they want to partner and build better communities. And they come with a lot of innovative and really great ideas. And so with that, we have community solutions. And I find that is the most satisfying part of the job, is working with communities to build up those solutions and to try and help rebuild fences and shift people away from the edge of that cliff. Cool. Thank you.
Wow, thank you, Carrie. I knew you were a nurse and an AMBO and a public health doctor, but I didn't know you were an artist. That's fantastic. We had a session yesterday. Nina Sue was presented yesterday, and she has her blog her podcast rather, is The Revolving Door. She came in her scrubs from paediatric ED, or ICU rather, and that revolving door that you see in the hospital does affect people a lot. All right, thanks for that, Carrie. Now we're going to hear from Josh Clark. So is this you, Josh? This one? So Josh is in training at the moment, and I had the absolute pleasure of working with Josh while he was doing his MPH and his dissertation. And in fact, I showed you the results of Josh's work in January when I spoke to you about it, when we walked through the system map that Josh built around the impact of ultra-processed foods and all of the reinforcing loops that have been created with the product development and with the marketing of ultra-processed foods, to show how we are trapped inside it and showing why it is really difficult to change. And so Josh will probably talk a bit about that, but he's going to talk mainly about his journey as a public health registrar, still with a stethoscope around his neck.
Tēnā koutou katoa, ko Joshua Clark tōku ingoa. Thanks, Boyd. I'm Josh. This is a photo from when I was a house officer, so it's a bit old, but I wanted to do a little bit of an homage to my new favourite TV show. And also to note something that Michael missed in his hard parts about the job. You can't rock around in scrubs anymore when you're a public health doctor, and I missed that. So I'm going to talk quite a bit about being a public health registrar, public health training in colleges and those sorts of things, and I'm going to mix that in with some of my story and why I've chosen public health and what I've learned from it. So we're gonna keep coming back to this slide. Don't read it all now, or you'll be bored every time I come back to it later. But it's a bit of a roadmap from where you guys are in medical school through to being the new Ashley Bloomfield, which is what all of us want. So for me, I went to med school here at Auckland. I've sat in this theatre. I remember my public health intensive. Is anyone here doing elder abuse? We've got the topics? Yeah, elder abuse? My people, you've got my back in. I finished med school, thank God. And I worked in Auckland as a house officer. So I was mostly working at Waitakere Hospital, North Shore Hospital, and in my second year, I wasn't really sure where I was going. I didn't necessarily like working in hospitals. It wasn't my cup of tea. But I got lucky enough to have a placement at National Public Health Service Northern Region, where Michael and Carrie work. And I spent 3 months there learning about public health, being exposed to environmental health and communicable disease and the upstream determinants and all the work that's done. And I sort of fell in love with it there. Because like Boyd and Michael and others have said, I didn't really know anything about public health coming out of medical school and through house officer years, but it's so important. And I guess the other caveat I'd have before I move on is that doing public health training as a registrar is one way to get into working in public health, but it's one of many, and there's lots of people who have gone down a heap of different tracks, become specialists in other field, maybe aren't even doctors, but are working in this capacity looking at the upstream determinants of health, the way that we can keep our communities healthy, protect them against disease, screen them, immunise them, do all those good things. So this is one way for sort of people like us to get into public health, but there's lots of ways to be a public health person. But we're here to talk about this. So to start with in public health, there's 2 colleges in New Zealand. There's the New Zealand College, which I'm part of, and I'm going to be largely talking about because it's what I know, and there's the Australasian College, or the other way around, the Australasian faculty. The important thing I want you guys to take away is that if you're thinking about public health training, the Australasian Faculty of Public Health requires you to have a Master of Public Health before you go in. So if you're thinking about sort of doing that training anyway, you're willing to self-fund it, or maybe you've already got one, then that's a potential option. But the great thing about the New Zealand College is that as long as you've got your general medical registration, which is your 2 years after being a house officer, they will pay for your masters. They'll pay you to do your masters, and then they'll pay you through the rest of your training as well. So it's a really great training program. Applications open in May the year before. It's kind of early, so if you're really thinking about it, don't miss that May deadline. But this is the path I took. So you apply, you do an interview, you get in, and then you become a basic trainee if you're with the New Zealand College. So basic training in public health is going back to university and doing a Masters of Public Health. And so a good thing about this is you can do it around the country. I did mine here at Auckland, but you can also do it through Otago at Wellington, Christchurch or Dunedin. It's a full time over 3 semesters, and it's mostly taught papers. It's a lot of sort of being in lectures, doing sort of assignments and essays and readings, having discussions about public health, talking with colleagues and lecturers about these big ideas. As I said, the college fully covers the fees, and you get paid a stipend. And you get to do a dissertation, which is sort of a big research project, and that often leads into opportunities around publication, which I'm still working on a couple of years later, and presentation. So I was lucky enough to be paid by my employer to go across to London mid last year and present my work, which apparently you guys all know about as well, with my maps, to a World Public Health Nutrition Conference. And that was an amazing experience. And it's the sort of thing that kind of happens in public health. You can do those sorts of things in lots of specialties, but because public health is a bit more academic, there's a lot more kind of being at conferences, talking about these big ideas, and doing that whole thing. Anyway, I need to hurry. The Masters is great because it builds that foundational knowledge. As I've said, I didn't know much about public health when I was in your position, and frankly, when I got into the program after 2 years of house officering, I didn't know much more. So the Masters is really great for getting back to basics, for learning the core knowledge and skills you need to then jump forward into a public health career as a public health physician. But it is back to university, it is back to more study, and it's a different style to med school. It's a social science more so than a sort of chemical science, biological science. It's a different style, but it's good as well. It's a really different thing. So you finish your master's, you do your dissertation, you graduate again, which is a bit fun, and then you start working as an advanced trainee. And so this is where I am. I'm the X, almost at the end of my training, but not quite there. Advanced training is 2.5 to 3 years of working in public health organisations. And you generally do 3 different jobs. So a lot of people follow a bit of a pattern of working in a regional service, like where Michael and Kerry work, and then working in a national service like the ministry or a national directory, and then a community organisation, which is sort of everything else, including universities, local councils, primary health organisations, Māori public health services. There are public health people in lots of different places, and places you might not expect. There's public health people in private research firms and Ernst & Young, the accounting firm. So there's lots of different jobs you can do, and it's really broad. I'm currently working at the Immunisation Advisory Centre, which is based here at the university, just across in the fancy new building. And I'll come back to that in the next slide. Great things about public health training as an advanced trainee, you have quite a bit of control over your pace. I work at 0.8, so 4 days a week, but I'm working 0.9 for my next job. I've worked 0.6 before. You can change around to suit your needs, and it's really easy. You have moderate control over where you go. Up until this point, we've still had to apply and interview for our different jobs, so it's a bit of a process, but that's going to change. And so by the time any of you were thinking about it, it's going to be completely different. But there's still quite a bit of control. You're not just directed, oh, you're going to Christchurch now to do orthopaedics down there. It's sort of, you have a say. So what does the work actually look like? I don't spend most of my days like this cat falling asleep in front of my computer. And partly that's because of this last point on the slide. No long days, no weekends, no nights as an advanced registrar. If that sounds too good to be true, it's not. But some public health specialists can end up working nights, so it's not forever. But it's a real plus. I mean, doing those things is exhausting, and being in a field where it's not, a requirement or a need is rare, actually. The type of work varies, so it depends a lot on what you're interested in. It depends on where you're working. It depends on what's going on at the time. If you're in a local public health service and there's a measles outbreak, it's all hands on deck and you're getting involved. If COVID-2 comes along, you're part of it. If your service is presenting to the local transport council or the local transport committee of the council on why we should have safer speeds, you can be part of that. So it's a really great opportunity to sort of be responsive, be involved in whatever's going on with the service. You also take on one or two big projects that carry you through the most of your time. These can be lots of different things. My current project, just as an example, is I'm doing qualitative interviewing with Māori primary care services, staff, vaccinators and managers at primary care services, talking about what the successes and challenges for them have been immunising Māori. And we're going to look to publish that. I'm writing up a big report, but it's been really interesting and it's really hands-on. It's getting out there, it's getting into the community, it's talking with people doing the work. It's been fun. The third thing that we do as public health registrars is there's a lot of learning and there's a lot of teaching opportunities. So there's regular teaching from the college, all those sorts of things. But there's also quite a few opportunities to do the sort of thing that I'm doing now. Come and talk to students, talk to house officers, talk to different people and organisations about public health issues that you care about, and that sort of thing. And so if that's something that you enjoy, it's a really great field for that. We'll skip along. So you've done your public health training, you passed the exam, I'm dreaming of that day, and you're the new Ashley Bloomfield. What does that mean? Well, Michael and Carrie have talked about this, so I won't labour it too much, but a really big part of public health is that upstream focus on the drivers and the determinants, and that was a real draw for me. A second part is, you have to. A second part is the core aspect of health equity and Te Tiriti o Waitangi. And as Michael said, it's quite an advocative field. If you're someone who cares about social issues, if you're someone who wants to get involved and sort of advocate for change in the community, this is a great field for doing that, and it's encouraged as part of your work rather than having to be, you know, your weekends and your free time. The work's political. And that can be a good thing or a bad thing, but generally the government, the media and other organisations, they're paying attention to the sort of thing you're doing, sometimes because they're interested and they really want it to happen, or sometimes because they really don't. But it's a challenge and it's interesting, and it can make it really great. The work is broad, everything from air quality to Zika virus. This is also a bit of a challenge, especially coming up to my exam when they could ask effectively anything. But it sort of comes from this place where we know that lots of parts of people's lives, probably all parts of people's lives, are drivers or determinants of their health. We know it's about where they work, how much they're paid, where they're living, how they grow up, all of these things. And so we sort of have this view that because everything drives health, everything is our business, and we're a bit greedy in that way. But it means that whatever you care about and whatever you're interested in, you can get involved with it through public health. And finally, communicating, teaching and engaging are core skills, and so if you like that, it's a good field. Kia ora.
Thank you so much, Josh, for that, and great to have those kind of nuts and bolts of the training, which I think people at your stage are probably starting to think about. I know the group that I took yesterday, we went around and people still already thinking about the specialties and what they're going into, and that does very much depend on what your exposure is. You do a run in anaesthetics or you do a run in surgery and you think, oh, this is quite good, then this is really interesting. So being able to do a run and to hear about what happens in public health, I think is great. Now, how do I get some light here? Light, teach, welcome, does that work? Okay, there we go. All right, many hands make light work. Right, now we've got a chance to have some questions. The chat is open for people from Pukawakawa and from the rural placement. Please send your questions through. We heard quite a bit yesterday, guys, about the importance of future medical leaders being able to speak up and ask really questions, like you talked about. Carrie, about always asking, but why? So we have a very smart class here, and we're going to hear some questions from people. Open to discussions and comments and questions. Yeah.
I was wanting to hear some ideas about how we can combat lobbying and like commercial forces. I think it's just the most insane thing that it's allowed. But how can we, as all of us, try to change that?
Oh, it takes a while, does it? Mute, take it off mute. There we go. Right, internal advocacy versus external advocacy, Michael.
Well, yeah, I think, as said, this is a great question for Boyd, but I think it's a lot about setting up good rules, actually, and what we have at the moment in New Zealand is the Wild West, that, you know, you can go from working for Philip Morris and then suddenly be in Parliament, and you can go from working for a minister and then all of a sudden the next week you can be working for a lobbying agency, and we have no no database of those who are working in Parliament, and we have very limited rules around funding. So I think the rules-based, there's some really simple things that we could do in terms of having a much more transparent arrangement. I think those kind of things will be in society, but it should be stuff that is not hidden, that people can discover, that we can keep an eye on where the money is going, who it's coming from. And at the moment in New Zealand, as he pointed out, it's very cloak and dagger, and I think that's where the worst of it will occur.
Just you or others might want to comment on kind of the advocacy within the system versus the type of stuff that Health Coalition or others might do, being kind of out there and public. So let's take speed limits as an example, right?
Yeah.
So you talked about that, and you've got access within the system to try to make a difference. And you talked about the data and the systems. How do you do that internal advocacy to be able to shift that up without getting your head chopped off?
Yeah, and I think it's really good to point out both internal and external advocacy being needed, because I think the groups outside that we'll see in the media calling for change give a platform for those working on the inside to actually get stuff done. So starting with government policy changes, they'll only be interested if they think that there are votes in it, and there'll only be votes in it if people are making a stink about it, and they'll only be making a stink about it if it's been talked about in broadcast public debate. But in the meantime, so we need the external sort of hard-hitting, what you're doing is terrible, but also within the organisations, once we've got those sort of external demands for change, you need to be able to get in there with a voice for health saying, okay, you're working on this, let's say it speeds, from a point of view of cost saving. How about I bring in the air quality impacts of driving slowly and what that's going to do to human health, and we can project that out over 30 years and what that'll mean for health system costs, and we can add that into the mix. And so I think then you'll have those, and you'll have those working right within government who are actually starting to draw the laws, write up bills and that, and being able to speak to them so that they're not just kind of the whimsical ideas of that have just come out of a headline, but are actually stuff that's built on good evidence, that's been evaluated, that's been tried and tested.
Thanks. Any other comments on the advocacy or the lobbying side? How do we combat the commercial drivers?
Yeah, I think there's much more to add, but I'll add that because I'm just starting out on my journey, I'm learning to become a bit more diplomatic in the way I talk. And I'm actually going to there's a lobbying talk on soon that I'm actually going to go along and listen to. But at the moment, I've been trying to learn the game. I'm a person that tries to profile and think about how other people think, and therefore where do I meet them halfway so that they can actually understand me. So, because otherwise I'd be talking to you and you wouldn't understand me and just completely shut off. So I try to find that relationship first and then go, this is where we're going to meet, and this is how, once I've got you on board, this is how I'm going to get what I need to get you there. And so it's about, I feel, supporting them to look in the right direction as to where we go. Currently, to do that for me, I do see I wear a couple of hats. Like I whakapapa to the north. I sit with iwi, and I also have a crown hat, and so I have to think about where I stand and those types of things. So what I end up doing is actually getting them to do a lot of the advocacy, but I help for them to get them there, and so that's that noise that gets created that gets that change and momentum going. And so I'm like the little sneaky person in the background, like doing that, but actually the community, like community champions, are actually leading that and making that change for themselves in that process.
Great. Yeah. Sorry, Michael. Yeah.
I was just going to give an example because I realised I was just talking in abstract. So you might be familiar with Greater Auckland, who write a blog about a lot of transport issues, the way we design our cities. So they made a big noise when Auckland Council and Auckland Transport released their plan for the Mercury Lane, one of our two new city rail loop stations that were opening, and a whole bunch of the roads that were going to be sort of improved and made much nicer for pedestrians, that sort of quietly scrapped that in the latest plan despite it being consulted on with the whole businesses, the stakeholders, over 2 years. So they did the external, like, what the hell, what are you doing, guys, this is terrible. On the back of that, because I work closely with Auckland Transport, Sean and I from my office had a meeting with the project team. And so they were like in damage control mode because there'd been a lot of media about it. And so we heard why they were doing it and sort of had this behind the scenes meeting, because my role, because I work closely with them, I can't go out in the media and say, you guys suck, what are you doing? Or else I won't work closely with them for very long. So that was the external part. And then the internal part, and we were looking at actual pedestrian walk flows and stuff, and we were able to advocate and sustain that there was going to be now some off-road separated footpath where there hadn't been before. So just an example of loud noise being required to allow the people on the inside to sort of push for a bit more.
Thanks, Michael. And just a final word on what's required to reduce the commercial, the terms and commercial drivers. So on Canvas, the example I talk about, the campaign, I do give the example of Let's Level the Playing Field, which is a Health Coalition campaign just launched with Helen Clark Foundation and Transparency International, and how we've kind of organised that campaign and our 5 asks around having lobbying legislation, slowing the revolving door, financing of political parties, managing conflicts of interest, and improving the OIA for transparency. So 5 asks is a lot, but you know, that's an example of the kind of campaign to try to put some counterbalance, and it's called Level the Playing Field because actually lobbying is an innate part of democracy. Actually, it's just that it is heavily weighted and influenced by the commercial people in the lobbying field, not the social lobbyists or the environmental lobbyists who are advocating on behalf of society and the environment. Okay, thanks. Great question. Right, other questions, comments? Yep.
You mentioned diplomacy. I just want to say, how do changes in successive governments impact your ability to make policies? Because we go from a conservative to a more liberal government, and you guys are staying the same. So how does that influence the government?
So just to repeat the question, it's a sort of the seesaw, the question of the seesaw between different political parties in power and the swing backwards and forwards, and how that gets translated into policy, of which we've seen quite a lot. Yeah.
I would say it's definitely tricky. It does bring a challenge. Part of the tactic is having the same goal, but maybe you need to frame it differently. So an example was with this new government, we were told we weren't to be talking about equity anymore, we weren't to be talking about Māori, and Te Tiriti's become very, poo-pooed. And we were all to talk about need. But all our evidence shows where the need is with Māori. It's with empowering Te Tiriti, it's with creating a more fair health system. So to some extent, you can shift the words you're using, but keep your goals the same, and persevere, because things can take many government terms to change and many different governments to come along. And as you point out, as sort of public sector, public health people, we are here through many, hopefully. So I think there's an element of knowing what your goal is, keeping or changing, being adaptive with your phrasing, but also striking when the iron's hot, and when there is a window of someone who's keen to make a change that you're keen for, being ready to jump at that.
Yeah, it is tricky, and I think part of it is also where you're positioned. Like we talked about being on the inside and the outside. If you're on the outside, you just keep saying it's important and you don't back down and you keep it in the public. That's not where I'm positioned. In fact, our work used to be under DHBs, which were in the machinery of government, we're one step removed. We were a public servant, but not actually part of the bureaucracy, and now we're actually agents of the Crown, so we can't do anything against government policy, which is quite a handcuff. So part of it is recognising the policy window. You learn in like part of your training about where there is an opportunity and how you're waiting for it to be ready. So we've done lots of work, for example, on marketing to children and the need for better regulation. And that's sitting there latent, ready for a minister who gives a damn about it, who wants to bring it in. It's not wasted, it's just there ready. But if you have been given a clear instruction by your minister that that's something they're not interested in, you just have to kind of be, as someone who's on the inside, sitting there on pause. Not saying that it's not effective, you know that it is, but you've just got to wait for the right moment and maybe have that conversation just on the inside, trying to change some beliefs.
Yeah, I think a great example of that was in the UK when they did a lot of work on what to do about reducing obesity and so on, and then suddenly the political window opened with Boris Johnson, who is obese, got COVID and nearly died, rescued by some Invercargill nurse, I understand. But anyway, he had the penny drop moment and said, what do we do about obesity? And Public Health England said, well, funny you should ask that. Here we have something we prepared before, and they pulled it out. And so very quickly it went from him being a policy champion, an incredibly unreliable policy champion, but a policy champion. The moment arrived, they put it in, and then all of those things were already made, and it got through to regulation and to legislation in a very short space of time. So yeah, these things aren't wasted, and we just have to have them hanging there when the window opens.
And the other thing I'd say is often things are politicised, but they don't stay on this, like they're not always like a right-left thing, they'll change over time. And like using the UK example, they've got far better childhood obesity plan for like 15 years that have all been introduced under Conservative governments, far better than anything that's come under a progressive government in New Zealand. So issues like air quality and that doesn't have to be a right-left thing. It's just trying to get somebody who you convince and then they move it. So I think just recognising that it's a dynamic thing and it doesn't have to be right-left, it can just be the penny drop.
Good question. Right. Any other questions, guys? You got one there?
Someone is wanting to know how much patient contact do you get in public health medicine?
Patient contact in public health medicine.
Depends where you work, so I would say very minimal. However, I think I practice a little bit differently where I like to go in and see people and use that as an opportunity to think about the bigger things and then talk to physicians and then create momentum like that. So so I will use that as a platform potentially as a learning experience and then go forth. But generally in public health we don't interact actually with patients themselves. But yeah, I think I work in a bit of a different community where people understand the social issues, and so we use that as the leverage.
Yeah, and you definitely don't interact with people where nothing happens because you've prevented something happening, right?
Yes, exactly. It's the hard part of the job, is no one says thanks. Because you can't say thank you to something that hasn't happened. So, yeah.
Good question. Any other questions, folks? Carrie, I wanted to just ask you, you put up that map of Northland, the red Northland, with the deprivation, and also we touched briefly on the spread of public health services and the fact that they're pretty thin on the ground. I mean, as well as obstetric services, there's public health services and things. So how do we fortify public health to cover those red areas? It seems like we're doing the opposite with only one person up in Northland. Is this just a dollar thing, or is there something else happening?
I think that's $1 million question. Yes, so I'm currently the only person up there working as a medical officer of health, and there's a lot of positions to fill, and I'm waiting for some friends to come. I do have the support of Auckland, and the issues up there are so broad and great that there's a lot of work to do. I don't know. Maybe it's just where people are at in their lives. Maybe schooling. Maybe it's to do with different people's needs and what they need for their own whānau. And so we move rurally, but there has to be some sort of attraction to bring everyone home. But once you're there, you sort of fall in love with it. And so it's getting you there, I think. So I've got to work out how to get people there.
Well, it's a great part of the world, and you're obviously pulled back by your whānau and by your community to say, come back and help sort it out. Okay, other questions, folks? You've got these amazing people here. Josh, sorry, yeah, go, mate.
I was mentioned about you don't have to be just like a specialist public health physician to be involved in public health. Say that those patients that could envisage a more clinical sort of career but still with an interest in public health things, like how would you sort of combine the two?
Yeah, good question. I think in some ways the world's your oyster, and once you get into whatever specialty you choose to do, you'll find that you have more control than maybe you expected, and more capacity to reach outwards and influence things. So I would say there's heaps of opportunities to get involved with research, and people who are surgeons or internal medicine doctors or anything like that, GPs, anything, can do research that is public health focused. You can sit on boards, join organisations like Health Coalition Aotearoa or other interest advocacy groups and be involved in their stuff. There's lots of ways, but even if you're just, you're in a hospital, you're working on a gastroenterology ward, and you notice that Māori patients, you do an audit, and Māori patients you find are getting less pain medicine than non-Māori patients. And you say, hey, this isn't right. Something's going on. We need to change this within our small team. That's public health in action. That's noticing something's going on with more than one person and making a change to the way that you're doing things. And perhaps that leads to, a national change or a change that influences other units. But you can the great thing about public health is you can sort of dip your fingers in and out of it as a clinical person.
Any other comments there?
And I'd also say, in a class like this, there's probably a couple of people who do public health medicine, and I think it's some of the best public health champions are clinicians who get it. So that's probably more of you is what we're really talking to. And so, just like Josh said, working at a bigger picture level. And the other thing I'd say is collaborate. Like you saw when I was with at council, that was a paediatric trauma surgeon who came in because he's seeing kids getting hit by fast cars. He doesn't have the background in epidemiology or to understand the actually, he's so into it now, he is. But understanding a population attributable fraction for air quality might not be a thing. We can bring that side. So I think the collaboration between specialties is also really important.
Yeah.
I'll
Okay.
just give you another example. Working on policy up north around alcohol. And so communities are having their say at the moment about if they want any more alcohol stores or whether or not they want supermarkets to sell at lesser hours, etc. And so we'll be going to a hearing for that. So my job is to hear the community voice, but then go find the data to back up what they're saying. But I'm also bringing in ED consultants who are going to talk about the ED side of things. I'm bringing in the mental health and addictions consultants to talk about the impact alcohol has on their people. I'm bringing in GPs who are talking about the impacts it has in primary care. And so all those voices together all come together. How can you say no? Once you've got all of that going, you've got that momentum going.
Just also to pick up on what all of you have said and what we showed yesterday, and that's the importance of recognising patterns, being able to see patterns of occurrence and look at the data. And if you remember the iceberg model of systems, you know, the first bit below the surface are these patterns which emerge. And Sue showed it yesterday with the patterns within the PHI, within ProCare, and you know, you talked about it within the Maori patients within the ward, or you showed it with the pertussis. You know, look, this is the job of doctors, to just not only see the things above the surface, which are the patients that are coming to you, but underneath that, the first level down, are those patterns, and being able to ask those questions that Carrie talked about, yeah, but why, you know, and follow those patterns down into the deeper underlying determinants. Further questions, folks? I just want to pick up on something that Josh said, and he made it sound like a fairly cruisy specialty, no nights, no weekends, that type of thing. But my guess is that once you become a lone public health physician in Northland, it probably changes the dynamics a little bit, doesn't it, Carrie? And being on call and going to call out emergencies and that sort of stuff. So tell us about the kind of night and weekend and call out and emergency type things that that you might get called to in public health.
Well, my last on-call was pretty intense. But so at the moment working in Northland by myself, I have to prioritise what I do. So I'm trying to be strategic about what makes the biggest impact at the moment, because I'm only one person and I also work part-time. So it's about where do I put the energy in, and what can I trust with other people to leave and do that mahi. So some stuff is slow rolling and other stuff is what we call the low-hanging fruit, and we pick it now. So that's kind of what I think about each day. Like, do I do something with this now, or do I just do something with this later when my friends arrive, and hand that over? On call recently, it ranged. So it started out with, I had a large fire in North Shore that you might remember. And then it was quite a large fire that involved every fire service that came in to respond to that. And then following that, we had flooding up north. So we had to manage a whole lot of sewage spills that had gone out to the community, because I knew that there was a tangi that morning and there was going to be people collecting shellfish, etc. So I didn't want them collecting shellfish because it was going to be exposed to the sewage, etc. That rain then moved down the country, so the flooding then hit the Whangarei area and further down south. So I had to follow that weather pattern, and then follow up with more sewage alerts, etc. So we had basically the whole of Northland covered in sewage, unfortunately, while that was going on. On top of that, we manage about 60 notifiable diseases. About About 60. There's about 60 notifiable diseases that are medical officer of health. 60 notifiable diseases, that you'll get notified about. So any one of those can come to you at any time. But particularly the ones we jump up and down are around like measles and meningococcal, so you're receiving notifications about that, and so you've got to work out those and how to stop the transmission of that disease going forward. So that's where you can work directly with whānau around vaccination, etc., chemoprophylaxis to stop onwards transmission of disease. I think that was mainly the main stuff that I had to deal with.
And the fire was about chemicals, was it? Toxic chemicals or something being released?
Yeah, that was the concern. Yeah,
right.
Yeah, and a lot of it is around managing community. So a lot of people, because we now of the day of phones and taking videos, people were going out to film it and expose themselves to potentially toxic chemicals. We don't want them doing that. And it was followed by the next morning was, I think it was Anzac Day, so people wanted to do Anzac parades at 5 o'clock in the morning, but we had ash and everything like that all over the place. So I was trying to manage the risk around that as well. So that was about communicating to the public about making sure they're informed about what the potential exposure could be.
It's pretty broad, isn't it? Yeah. Michael, the balance between infectious diseases and non-communicable diseases in the work that you do. I mean, most of our health problems come from non-communicable diseases, and they have deep, public health and societal causes. But what burns up your time or the time of the service I guess, is on those acute things, on the acute outbreaks. And so how do you create that sort of balance, or how do you, I guess, bring the non-communicable diseases into the workload because they're non-urgent, you know, they're just slow burns, but they're big burns?
And that's always the challenge, that we're kind of trading off those things that as you say, acutely an infectious disease outbreak will get a lot of attention, and I think there's probably a gravity, like a natural default within our agencies to those things, because the causal links are a lot clearer, at least in people's minds. So you know that if we don't do anything, we will default to just looking after infectious disease outbreaks and deprioritising the 80% of health loss that occurs in New Zealand from long-term conditions. And that's what happens in our agency, just like it does right across the board. And so recognising that that's the default that you've got to try and work against. So there's internal lobbying about the importance of these things. There's other mechanisms. We try like a business continuity plan and that sort of thing. But I think I will kind of flip it and say one thing I love about my job is being able to do a bit of both. And people have been asking about like the clinical contact and stuff. And I think it's nice to be doing something kind of reactive and quite quick about a little disease outbreak. I don't like that if that's all I'm doing, because again, I just feel like I'm maybe only halfway up the cliff at that point. And when I'm working on, creating a safer transport system, I feel like I'm actually moving people way away from the cliff. So I get to use the medical knowledge for both, and particularly in that sort of infectious disease space. But I think, having the balance of the two is a much more satisfactory kind of way.
Okay, folks. Any other questions? Where's the inquisitiveness in the class? Listen, I've got a whole pile of questions that I think these guys need to understand. And can I just ask you about something which is quite tough, which is these latest reforms in the health system, which has impacted public health quite severely. When the PHI legislation, which is the new legislation that came in, which disestablished DHBs and brought in this new system, Te Whata Ora, and originally Te Whaka Te Ata Ora, it came with a lot of fine words and a lot of hope. I'd be interested in your sense of the reality of that and how these new reforms have impacted on public health and your ability to do the job that you think needs to be done, for better or for worse. Now, I know this is a bit, but the doors are closed. These guys are not going to take it any further.
No, so I think, going right back to the start of it, like I think the intention and the potential of reform has been good. I didn't have a problem there. In fact, they're originally setting up a separate Māori health agency with commissioning ability to, really lift some outcomes there. Awesome. But I'd say one thing is it's been the biggest, like the health sector in New Zealand is, now that we're Te Whatu Ora Health New Zealand, there's over 70,000 employees. We're by far the biggest employed agency in the country. And the implementation of the changes has been really clunky. And so that happened 3 years ago, and we've had 3 smaller restructures on the way through, and a lot, like it's the systems around which we operate in have gotten kind of more and more difficult to work through. So whereby the DHB system had plenty of flaws, and any system will, what's really helpful in any system is clear accountabilities and lack of duplication, because you need to know who I need to talk to about this issue that's not my responsibility, and I need to know where it crosses from being me to being somebody else. And I think what's really happened over 3 years is that has just got very, very murky. So there might be 2 groups. I can count about 4 different groups doing health intelligence across the country.
Oh, really?
And so, if you've got ESR, you've got ISK, you've got NPHS. And so who is the one responsible for monitoring, say, pertussis spread? And when there's multiple responsibilities, it's very hard to know who really holds it at the end of the day or who you escalate things to. So, I don't want to get organisationally. I think that the issue is there's a lot of lack of clarity at the moment, and we're still sort of working through that. And in the midst of that, a lot of the desired outcome of the initial restructure has been ripped out of the middle of it. So, I think there's amazing people working in the system, great work to be done, but at the moment the actual system is not an enabling one, it's one that you are having to really duplicate effort, do more to get something good out of it. That's my view.
Carrie or Josh, any reflections?
As I say, I'm still learning to be diplomatic. But,
You can practice your diplomacy now, Carrie.
I wasn't initially very, very excited about PHI order and what it was the opportunities it was going to bring, and I saw just so much potential good that could come from this. And then when we started going through the restructure process and removing, Te Aka PHI order and the Māori Health Authority, etc., I was viscerally quite angry about it. This was in the context of the changes that were happening in government as well, with, I call it the Māori bonfire of policy and stuff that was happening. As I mentioned before, I feel like I wear 2 hats, so I was trying to work out where I stood and what I represent. So I was going through a bit of that internal conflict of what that meant in my own internal values, and also being a new consultant. So I was trying to navigate this new process, and so I had to talk to a lot of people to get that guidance on how to keep myself safe, but also what am I doing for the community here. So what I ended up doing, which made me feel a lot better, was I wrote a letter, but I didn't write the letter. I got the community to write the letter. And I put out a survey and asked them questions, and then I said, I'm going to bring it all together and I'm going to stamp my name on it. And because I'm the medical officer of health, that's the advocacy part of it. And I sent it to everybody, and I'm aware that Nick Chamberlain lives in our town, so I put it in his letterbox and I just put it on his desk, etc. And that got attention, and I just said, basically it said, what are you doing? This is a high need area. We've got a lot of deprivation. Here's our situation. Here's our solution. Why aren't we doing this? And so this is what the community wants, and this is what they're saying. And aren't we supposed to be doing a ground-up approach to our health reform? And so give me a good reason why we're not doing that. That was kind of the letter that it said. And from that, people did listen, and we have seen some services maintain. But also, as I mentioned earlier, I have a community that's really resilient, and we are bringing up other things outside of this current system. We create our own systems. It's just invisible to other people. But if you know how to navigate that, you use it. So it's kind of like when you have a heart attack, you create new blood vessels. So that's what we do. We just make things that keep flowing. So it's about being in that community and knowing those lines of access to actually continue your day-to-day process. I hope that kind of answers that.
Thanks. Josh, any reflections on coming into this?
Yeah, it's funny for me because I've only really been in public health during reform and restructure, or pandemic. So I'm not too sure. I think in some ways you learn skills of how to deal with restructures and reforms, and how to navigate that and look after the kind of people in your organisation, your teams and around you. But it's pretty trying and it's pretty ugly. And I think being on the ground and knowing people who are working really hard towards issues you really care about are just sort of getting cut for dollars is pretty rough. And it makes you angry, and I think that's okay as long as you use it for something like Carrie's saying. Yeah, it's hard. Hoping for settling. So.
Settling down, yeah, it's probably similar to what's happening in the healthcare services generally, I think, with excellent people on the ground who are doing really the hard mahi, and they're trying to make as best they can, but the system, and especially through the uncertainty of restructuring, is a depressing factor. And the health system went through a lot of restructuring in the 1990s. And then we had a sort of period of stability with the DHBs for 20 odd years or something. So I hope that some of the problems of having 20 DHBs and all the different systems that they operated in, and different levels of kind of funding that was somewhere a bit inequitable, that some of that is being sorted out. But the sense I get from both people within the healthcare system and in public health is that they really want this kind of restructuring to be over and to be able to get to some level of stability, and to try and build up capacity again. Okay, last chance for any final questions, folks. Yep.
I just have a question. I feel like you've kind of touched on it, correct? But I'm curious about, you guys kind of got two hats. You've got the public health hat where you know all the information, you know what needs to be done. And then there's the communication, the changing rules, the getting people mobilized in the direction. I'm kind of wondering about your thoughts from a sort of psychological perspective about how you actually get people fired up, because something tells me it's not just telling them the facts and the figures.
Motivating people, motivating your community.
That's,
Carrie, you kick it off.
That's probably, when you do your mental health run, you start to learn about different ways of thinking and what motivates people. And so it's that kind of, you think about, like something makes you want to do medicine, right? But we've got a connection with medicine. We both want to help people, So I'll use that as a lever to get access to us connecting a bit more, and then I'll ask you a few more questions, and then I'll plant a seed, that kind of thing. You'll get on board with that. Go, oh yeah, that sounds like a good idea. I'll leave it for a bit. I'll come back to you a bit later, and then bring it up again, and then by then you've had a time to think about it. You might have had a few more people talk to you about it, and that's kind of how that ball starts to roll. So that's how I start motivating people. I won't do it all in one go, but I'll build that relationship so that we trust. But I also want to hear your ideas too, because that will help me build where I like my thinking as well. So it's collaborative, yeah. And I end up working in that partnership kind of thing. So. Everyone has strengths, it's just that we've got to work out how everyone uses those to actually create that change. Yeah.
And I'll just jump in with, I think what you're really identifying is that we don't live in a world of rational policy making. Like, it's not like, let's look at the problem, let's get some evidence. Great, we know what works better, let's do that now. I mean, but you actually, coming from medicine, you sort of expect it to be that, because that's sort of how medicine works. Like, okay, let's investigate this new therapy. Is it better or worse? It is. Okay, a new standard of care, let's move on. So you come into public health and you're like, great, that's the same thing. Let's go to the universities, find out what needs to happen, and then it'll happen. And then you're like, oh, policy doesn't work like that at all. And I think, so a big part of my sort of latter career development, and certainly ongoing, is about how to build community movements, coalition building, and that sort of, learning from like the civil rights in the 60s, and like these types of things are actually how we, that and behavioural science, like how our brains work, social change sticks, those types of things, how we can tap into value sets to change people's beliefs rather than thinking that just new information will change someone's behaviour. And so I think it's really, it's the key. There's a lot to be developed there. I'm certainly still learning on those aspects. It's definitely part of the ongoing development on the job.
Carrie, you mentioned before trying to think about being in someone else's shoes, and which is essentially empathy and understanding where they're coming from. And people will come with their own values and their own mindsets, and unless you can empathise with them, doesn't mean you have to agree with them or that you don't have other points of view, but unless you can see where they're coming from, then you're not going to be able to persuade people and get on board. And so even things like the regulatory standards bill that's going through Parliament at the moment, where it has two values driven by David Seymour, which is around property rights and individual freedoms. And these are actually important. Property rights and individual freedoms are actually important, and they need to be protected. But there's more to it, But we don't get by sort of dismissing that as rubbish. That's not actually true. These are important, but there are other considerations that need to come in. And so I think empathising not only with your patients is actually critically important, but in population health, when you're trying to build coalitions, when you're trying to get on, when you're trying to get stuff through the politics, through the systems like these people are, and through the communities, then empathising where people are coming from, what are their values, where are they standing, gets you in good stead for, I think, getting some common outcome. Righto, folks, that's fantastic. That's probably a good place to finish. So just join me in thanking these three wonderful people for their time and their expertise.